session of our course. Today's session, we are going to cover the last chapter or the last section of the curriculum, which is the diseases of the posterior segment. So today's session, or the topics that are going to be covered in the posterior segment, it will be a brief overview of retinal investigations. Then we will go through the vascular retinal diseases, then the macular diseases, then the fundus and the macular dystrophies, and then also an overview about the surgical retinal diseases. So let's start immediately by some overview about the retinal investigations. So as we know, we are an exam-oriented course, so we are trying to spotlight or make like focus on what is required in the exams from the retinal investigations. Because if we try to just cover everything, it will take like a whole course, and we're already having a parallel course for retinal investigations in case that you don't know. But let's start first by what are the investigations of the retina and the macula that could be asked or appear in the exams. It will be anything from fundus fluorescein angiography to the indocyanine green angiography to optical coherence tomography, OCT angiography, and electrophysiology. However, the good news is that the OCT angiography and electrophysiology, there won't be an image that you should be asked to interpret. So you could have an image of a fundus fluorescein angiography or indocyanine green angiography or optical coherence tomography, and you should be asked or you should know how to interpret them. But for the OCT angiography or the electrophysiology, you may be asked only about some general principles or the interpretation without a photo, without need to read an OCT angiography photo or electrophysiology graph. Okay, so let's start first by the fundus fluorescein angiography and knows what is the principle of the fundus fluorescein angiography. Basically, it is fundus. So we want to image the fundus by a dye called the fluorescein. In order to delineate the blood vessels, it is angiography. So basically, it is a kind of dye that is injected intravenous called sodium fluorescinate. They are injected into the cubital vein, and then they will reach the systemic circulations until they reach the ocular circulation. So the fluorescein molecule will reach the ocular circulation until it will start first by the choriocapillaris. So you see here, there are some green and bluish molecules. The bluish one will represent the free fluorescein, while the greenish one will represent the fluorescein which is bound to the plasma proteins. In case of fluorescein, 85% of the fluorescein will be bound to the plasma protein, while 15% will be a free fluorescein. You find here the choriocapillaris will be the first station which will encounter the fluorescein, so you will find that it is fenestrated. There are openings in the choriocapillaris, and these openings will allow the free fluorescein to leak out from these fenestrations. So this will be responsible for what's called choroidal flush. The choroidal flush is the first stage of the fluorescein angiography, which will be due to leakage of fluorescein through the fenestrated choriocapillaris. Then the blood will be shifted from the choroidal circulation to the retinal circulation. And as it goes through the retinal circulation, you will find that it will encounter what is called the blood-retinal barrier. The blood-retinal barrier is composed of outer layer and inner layer, or outer barrier and inner barrier. The outer barrier is called the retinal pigment epithelium, the tight junctions between the retinal pigment epithelial cells, and this will not permit free flow of the fluorescein molecules. Also, the inner blood-retinal barrier is formed by the tight junction between the capillary endothelial cells, and this also will not allow the fluorescein molecules to get out of the retinal capillaries. That's why normally the fluorescein should be within the retinal blood capillaries or within the retinal blood vessels. If it is present outside the retinal blood vessels, then this is a pathology. There is an abnormality. Okay, So this what will make the fluorescein angiography useful for delineating vascular retinal diseases, because it should be within the retinal blood vessels, shouldn't be out. If it is out, this is a pathology. However, it is normally to be outside the choroidal blood vessels due to the fenestrations of the choriocapillaries. So what are the phases of the fundus fluorescein angiography? So these are the pathway of the fluorescein. The starting by the choroidal phase. So once the injection done, then there is a time from the injection till the fluorescein first appear in the fundus through the choroidal phase. This is called the transit time, it is the arm to retina time. Arm to retina time, it is the time that the fluorescein takes in order to reach from the injection from the arm in the arm until it reach the eye, and until it reaches the choroidal circulation. This should be around 9 to 10 seconds. If it is delayed, like if it is like 20 seconds, for example, then we should suspect that there is a presence of some pathology in the internal carotid artery, which will be the pathway through which the fluorescein will pass from the arm to the eye, and maybe like there is a carotid stenosis. This is what happens in a disease called ocular ischemic syndrome. Okay, so this is something that we should be aware of. Okay, so starting by the choroidal phase, you see that the fundus is showing patchy filling. There is like granular appearance, grayish appearance of the fundus. And this is due to the fenestrations in the choriocapillaris, and this is due to leakage from the choroidal capillaries in the early phase of the fluorescein angiography. It's also, you may notice that there are some filling of like nasal and temporal blood vessels. What are these blood vessels which are filled in early phase in the choroidal circulation? This is the short ciliary arteries. Short ciliary arteries are filled during the choroidal circulations because they are branches from the choroidal blood vessels. So these are responsible for supplying the optic disc. So these are can be included in ischemic optic neuropathy and will show defect in the filling of these arteries in the early phases for cases of ischemic optic neuropathy. Then after that, the fluorescein will go toward the retinal blood vessels. So to start first by filling the retinal arteries, which is called the arterial filling or arterial phase. So you will see that the arteries, retinal arteries, the superior and inferior nasal and temporal branches of retinal arteries become filled with fluorescein. And you see that the fluorescein is normally only present within the blood vessels, but the veins are not filled. Then the fluorescein will shift from the arteries to veins. In this shift, it is called arteriovenous phase. So the arteries, the fluorescein will pass from the arteries to the arterioles, to the capillaries, to the venules, to the veins. This phase is called the transit phase, which will be like around 1 to 2 seconds. And in this case, how would we know it in the fluorescein angiography? By the presence of lamellar flow. So you will see that there is a staining of the wall of the veins. This is called lamellar flow, which indicates the arteriovenous phase. After that, the whole veins will be filled. So there will be completed venous filling, and then the whole blood vessels of the retina are filled, and then there will be recirculation of the fluorescein. So the fluorescein will be excreted by the kidney. Then another wave of fluorescein will stain the eye. So as the fluorescein as the recirculation of the fluorescein happens, there will be staining of some ocular tissues like the optic disc. As these discs as these structures have high affinity to the fluorescein, so they will get a stain every time the fluorescein will circulate into the eye. However, for other parts of the retina, like blood vessels, you will see that the fluorescein will be faded will be decreased or washed out from these blood vessels as it is excreted from the kidney. Okay, so these are the normal phases of the fluorescein angiography in a normal individual with no pathologies in the retina. So let's cover some topics which can be sometimes asked in the MCQs exam, like why the fovea looks dark. So there is, first of all, if you remember from the anatomy, the fovea is avascular. So as you know, the presence of fluorescein in the blood vessels, what will make it look hyperfluorescent or looks whitish. If there is no blood vessels, it will look blackish. Okay, so this is one thing. The other thing is that the melanin is present in the fovea is more dense, or the retinal pigment epithelium present in the fovea more tall, more densely packed, and has more melanin content. So this melanin is a pigment. It will cause blockage of the underlying choroidal fluorescence. Also, there will be the fovea looks yellowish because of the presence of another pigment called the xanthophyll pigment. So this xanthophyll pigment also will cause blockage of the fluorescence. We will cover now what's meant by blockage, but just for now, it is due to avascularity and also the presence of high increased density of the pigments, either the retinal pigment epithelium, either the melanin from the RPE or the xanthophyll pigments. Let's now talk about the causes of hyperfluorescence and hypofluorescence. First of all, let's see the causes of hyperfluorescence. Where should we see abnormal increase in the fluorescence, which appears in whitish color? First of all, in the what's called window defect. A window defect is when there is a defect in the retinal pigment epithelium, so we can see the fluorescence of the underlying choroid. So as we just mentioned that there is all this is patchy choroidal filling, then this patchy choroidal filling or the choriocapillaries are covered by a layer of retinal pigment epithelium. So this retinal pigment epithelium causes masking of the fluorescence, masking of the hyperfluorescence of the choriocapillaries. But what happens if there is an area, localized area of RPE atrophy? If there is an RPE atrophy, so there will be more effect of the choroidal hyperfluorescence. It will be more pronounced. It will be more bright. So if it happens in the early stage of the fluorescein angiography in the choroidal phase, it is called RPE window defect or hyperfluorescence due to window defect. Okay. This is one thing or one cause of hyperfluorescence. The other cause is called pooling. Pooling of the dye, meaning that there will be a hyperfluorescence which will be confined within a certain anatomical space. Like if there is increase in the dye under the retinal pigment epithelium due to retinal pigment epithelial detachment. So it will show this hyperfluorescence, which will appear with well-defined edges or well-defined margins. So this is a patient with RPE detachment causing pooling of the dye in a certain anatomical space. Also, if there is neurosensory detachment, like this patient has both neurosensory detachment, so there will be accumulation of the dye below the retina, and also RPE detachment, so there will be accumulation of the dye under the RPE, resulting in the pooling of the dye. So pooling again is another reason for pooling or for hyperfluorescence. So to give some clinical examples, like the RPE window defect occurs in bullseye maculopathy, where there is atrophy of the retinal pigment epithelium, as what happens in the chloroquine toxicity and other diseases such as cone dystrophy, Stargardt disease, and others. Pooling of the dye can occur due to a pigment epithelial detachment, as we just mentioned. And under the sensor retina occurs in central serous chorioretinopathy, where there is active RPE pump. So there will be fluid under the neurosensor retina. So these are the cause of hyperfluorescence. What are other causes? It could be a leakage of the dye. So it means that there is abnormality in the retina or the blood vessels that will result in that the dye is not settled in the blood vessels. It will leak out from the blood vessels. For example, it could be that there are some inflammatory mediators. There are some inflammatory mediators present in the retina that will cause that the blood wall of the blood vessels will be leaky to the fluorescein. Like for this case, there is hot disk, there is hyperfluorescence at the disk, and there is here a petalloid appearance of the macula. So there is hyperfluorescence at both the disc and the macula, which occurs in what's called Irving-Guss syndrome or postoperative cystoid macular edema. So here the leakage of the dye is present into the sensor retina. Also, the leakage of the dye can occur due to presence of new blood vessels, like presence of new vascularization, as what happens in many proliferative retinal disorders. These blood vessels don't have the normal wall like the normal retinal blood vessels, so they will tend to leak the fluorescein. Also, we can say that staining is also another way or another form of hyperfluorescence. So staining means that there are certain structures that tend to attract or has high affinity to the fluorescein. So with every circulation of the fluorescein, they will take the dye. Like for example, what happens in optic disc, or if there is a sclera, like if there is chorioretinal degeneration, so the sclera will take, the collagen of the sclera will take the fluorescein. Also, if there is a scar, some scars, also membranes like choroidal neovascular membrane. So this membrane will take the blood vessels, will take the stain, so it will show late staining in the late frames. There is another concept which is called the fundus autofluorescence. So what is meant by fundus autofluorescence? It is meant that there are some certain structures that will show hyperfluorescence but without injection of a dye. How does this happen? So in cases of fluorescein angiography, the fluorescein molecule itself will absorb the blue light and emit a yellow-green light. For cases of, for some diseases, like optic disc drusen or astrocytic hamartomas, the lesion itself has the property of autofluorescence. So it will give the same behavior like the normal fluorescence, as if we are exciting the material by, as if we are exciting this material by a blue light, it will emit the yellow-green light, even without injection of a dye. So it has the same property of fluorescence like the sodium fluorescein molecules. But the difference here, not only that it is showing hyperfluorescence without a dye injection, but also that the autofluorescent lesion doesn't show the high hyperfluorescence like the a lesion with hyperfluorescence with the dye. So it will show autofluorescence, meaning that it is hyperfluorescence but minimal hyperfluorescence, not very high hyperfluorescence. Okay. So it's sometimes believed that this hyperfluorescence or these autofluorescence are due to defect in the retinal pigment or stress in the retinal pigment epithelium, but or indicating that the retina has a severe pathology. Like for example, as they proved that by when they saw the areas of geographical atrophy, they will show a autofluorescence at the edges of the geographical atrophy, which means that the retina is severely diseased or severely compromised. But anyway, this happens. This is for the exam. You should just know that this lesion or hyperfluorescence, hyperautofluorescence occurs in these two lesions, the optic disc drusen and the astrocytic hamartomas. So what about the hypofluorescence? The hypofluorescence is when there is blocked retinal or choroidal fluorescence. So we just mentioned that the fluorescein will pass through the choroidal circulation and retinal circulation. If there is anything that will mask or block the appearance of fluorescence from the choroidal vessels or retinal blood vessels, then this will result in hypofluorescence or this blackish color. So blocked fluorescence occurs when the stimulation or visualization of fluorescein is blocked by either blood, like if there is like subretinal hemorrhage, or if there is pigment, as we just mentioned, if there is like choroidal nevus, if the pigment, if there is RPE hypertrophy, as in congenital hypertrophy retinal pigment epithelium, any pigment can cause blockage of the fluorescence. So here we can see that there is a blood in the fundus photo, and you can see that there is the underlying choroidal, choroidal fluorescence is not apparent because of the blocked fluorescence by this retinal hemorrhage. And also you can see here that this is like the presence also of hemorrhage, which is blocked by this lesion, which can be either pigment or blood. You need to refer to the colored photo in order to differentiate. The other cause of hypofluorescence is that it could be that there is no any abnormal deposition of any material, there is no hemorrhage, there is no pigments, but it is just that the blood vessels didn't reach that area of the retina. So then, since that there is no blood vessels, so there will be hypofluorescence. For example, it could be that the blood vessels is present, but it is occluded. Like for cases of all ischemic proliferative retinopathies, like ischemic proliferative diabetic retinopathy or ischemic vein occlusion. So there will be occlusion of the blood vessels, resulting in that the area supply in the retina supplied by this blood vessels is not perfused. So it will show no fluorescence. It will show hypofluorescence. So this is called capillary non-perfusion or capillary dropout. It is due to occlusion of the blood vessels. Or the blood vessels could be intact. However, there is loss of the vascular tissues. There is no vasculature in the first place. Like for example, in case of high myopia, the ocular wall will stretch, but this will not be corresponding to the increased amount of the blood vessels. So this will result in areas of areas that doesn't have a vascular blood supply. The same thing with the choroideremia, where there is degeneration of the choroidal blood vessels. So this will be showing areas of hypofluorescence due to degenerations of the blood vessels. Okay, so this is about the fluorescein angiography. The other investigations modality, which is similar to or has the same principle like the fluorescein angiography, is called the indocyanine green angiography. So this is another material that can be injected in order to do angiography, to check for the choroidal and retinal circulations. So why would we need another material than the fluorescein angiography? So if you, for those who are attending with Dr. Amin investigations course, he would tell you that the fluorescein angiography is every now and then is becoming like an obsolete way of investigations to retina. Like it is hazardous. It is shouldn't be given for patients who have enough iodine allergy, or they have toxicity in the retina or in renal impairment because it is renally excreted. Also, it can show anaphylactic shock. So sometimes some patients will develop severe hypersensitivity reaction from the fluorescein. So it is not very safe, and its uses in ophthalmology are becoming limited every now and then. And it is now there is like a paradigm shift in order to shift to other modes of investigations which are becoming more safe and more effective. So indocyanine green, it can be a little bit more safe and more effective. So it is more safe. It will cause less nausea and vomiting, but it will be maybe also the same ratio of anaphylactic shock. But it is more effective in terms of delineating the choroidal circulation. So the problem in the fluorescein angiography, as we just saw that any that it is the fluorescein, it is masked by the retinal pigment epithelium. So if there is any pathology in the choroidal circulation, it will be masked by the retinal pigment epithelium. And the advantage here of the indocyanine green is that it utilizes the infrared light, which has longer wavelength, and this infrared light will be able to delineate the choroidal circulation better. Also, the molecule of indocyanine green, like 98% of it bound to proteins, so it will stay within the choroidal circulation. It will absorb the light, the excitation light, leading to more delineation of the choroidal blood vessels. So this what will make it superior to the fluorescein angiography in checking the choroidal diseases like polypoidal choroidal vasculopathy. So this was asked before in the exams, that the indocyanine green angiography is better than the fluorescein angiography in polypoidal choroidal vasculopathy. Okay, so this is for the indocyanine green. So the question here, sometimes you maybe got confused. How can I differentiate? If I see this photo in the exam, how can I differentiate whether it is a fluorescein angiography or it is an indocyanine angiography? Simply look at the optic disc. The optic disc in the indocyanine angiography looks blackish, unlike the fluorescein angiography, which will look whitish or grayish. Okay, easy. Okay, fantastic. Let's now check the other modes of investigations, which is optical coherence tomography. So optical coherence tomography can be considered the other face of the ultrasound. The ultrasound taking sections within the eye and uses the ultrasonic waves. The optical coherence tomography will take sections in the posterior segment or the anterior segment, but instead of using the ultrasound waves, it will use the low coherence interferometry. It will use laser light. So it will cause a low coherence interferometry. The interference between the laser waves will result in construction of images of cut sections within the anterior segment or posterior segment that can be used to give a virtual overview of the layers of the structures, the structure analyzed. Like, for example, it has many uses. It can be used for posterior segment diseases in order to delineate or to visualize the posterior segment layers or the retinal layers and the choroid as well, and the vitreoretinal interface. Also, it can be used to it can be used for glaucoma. As we said in the glaucoma lectures, it can be used for measuring the retinal nerve fiber layer thickness in the 4 quadrants. Also, it can be used for the anterior segment, so can detect any angle anomaly, whether there is plateau iris or there is narrow angle or angle recession, or it could be used for iris lesions such as the presence of iris melanomas. Also can be used for biometry to measure the depth of the anterior chamber. So it has many uses. Regarding the interpretation of the OCT retinal images, the device will construct an image which can be a color, giving it a color code, or giving it, or it can be blackish and whitish. So it is like a pseudo color. So the hyper reflective layers will appear more in hot colors like orange or yellowish. The hyporeflective layer will appear with more blackish color. So by this color code, we can know the presence of any abnormality within the retina, and also by the arrangement of the retinal layers. If there is any abnormality in the arrangement of retinal layers, we also can know if there is any pathology. So starting first by there is here the choroid, followed by the hyperreflective layer, the retinal pigment epithelium. Then the junction between the the photoreceptor inner and outer segment, then external limiting membrane, outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, and the ganglion cell layer. So as we go through different retinal diseases, especially in the macular diseases, we will cover how does the OCT will be different, or what will be the abnormalities in the OCT angiography or in the OCT retinal images. So speaking about the OCT angiography, OCT angiography is relatively a new modality of imaging, and it evolved because again it is safer than the fluorescein angiography. So the fluorescein angiography will be showing the retinal blood vessels but with injection of a dye. So if a patient is allergic to the fluorescein or indocyanine green, it will be better to have non-invasive mode of imaging like OCT angiography. So I guess that you can see now this image and see what is this. This is the Google Maps, and I believe that every one of us is using Google Maps, and there are many occasions where we got stuck in the road by the traffic. There is a traffic jam, and we would know some clues from the Google Maps by the presence of some color codes, like the bluish here looks like it is normal flow. The orange will be a little bit of stuck, and red appears to be totally stuck, so there will be delay in the cars. Well, how did Google understand that there will be a traffic jam, or if there is delay in the traffic? This will be by simply analyzing the movement of the cars. So analyzing the movement of the cars, whether the cars are stuck or they are stand still in their places or they are moving. So it will give like this color code and would analyze and interpret what will be how much your journey will take, and how much and what will be the condition of the road. It will be the same principle of the OCT angiography. So if we just remove the cars and replace them with the RBCs, so this will be the principle of the OCT angiography. So the OCT angiography is a way for imaging of the vasculature of retina and choroids, and by meaning that the device will use a laser light that will be reflected from the moving RBCs to outline the vessels. So the RBCs are moving within the vessels in the choroidal circulation and in retinal circulation, and this laser reflected from these RBCs will tell us if there is new vessels here or new vessels there, or there is avascularity or ischemia here or ischemia there. So it will give us a clue about the condition of the retina, whether it is vascularized or there is ischemia. So it will also show the presence of high flow rate or areas of low flow rate or areas of no flow, the same principle like Google Maps. So this will be a breakthrough in the retinal imaging because it showed early cases of like neovascularization in the choroidal neovascularization, where it can't be evident by the OCT, or the neovascular membrane is not very evident by the OCT or the fluorescein angiography. It will be evident, the slightest amount of neovascularization can be evident by the OCT angiography. It will also will be able to detect the level of the new vessels, whether there is a superficial plexus or a deep plexus. It will be able to know what is the exact level of these new vessels or the abnormal blood vessels. So it has many uses in ophthalmology. It can be used for diabetic retinopathy to detect microaneurysms and new vascular complexes, foveal avascular zones, and areas of non-perfusion. It can be used for dry age-related macular degenerations to show the generalized decrease in the choriocapillaris flow, and typically extending beyond the borders of the areas of atrophy in case of geographical atrophy. Wet age-related macular degeneration will be very, very essential, very, very useful for quantitative and qualitative assessment of the choroidal neovascular membranes and for follow-ups, and also for central serous chorioretinopathy to differentiate between the choroidal neovascularization and the pigment epithelial detachment, especially when the fluorescein angiography are overlapped. So it will be sometimes very difficult to differentiate between these diseases by the fluorescein, and here it comes the rule of the OCT angiography. Finally, let's come to the final investigations, which is the electrophysiology. So the electrophysiology is a way to record the electrical activity from the retina divided by different layers. So it is just we are measuring the electrical response from the retina. There are different ways to measure that. First one is called electroretinogram. Electroretinogram is measuring the mass response from the retina in the form of an electrical impulse. It will be divided into different waves. First wave called A wave, then B wave, and there is some small wavelets, small waves on the ascending limb of the B wave called the oscillatory potentials. And for sometimes there could be another wave called the C wave, but it is not very common to see it. So the main waves here are A wave and the B wave. It's important to know what will be the source of each one. The A wave is a negative A wave, or is a negative wave, which is the source of it is the photoreceptors. So it comes from the photoreceptors. It will be the first negative wave after the isoelectrical line. Then the B wave, which will be the positive wave after the A wave, and the source of it will be the bipolar and molar cells. There will be small wavelets come from the ascending limb or superimposed on the B wave, are called the oscillatory potentials, and they are coming from the amacrine cells. And finally, the C waves are a positive wave. Sometimes appear their source is from retinal pigment epithelium. However, there is another kind of electrophysiology modality for measuring electrical activity from the RPE called electrooculogram. We will come to that in the next one. So the most important here is the A wave and B wave. And as you notice that the A wave is negative and the small wave, and the B wave is positive and it is large wave. So if we divide B wave on A wave, so if we divide the amplitude of the B wave over the amplitude of the A wave, we will get a value which is more than 1. So this is the expected, this is the normal. And in this case, it will be called a positive B to A ratio. Sometimes this ratio is becoming negative, like there is called negative ERG. And negative ERG is when the B wave is smaller than the A wave. So we see here that this is the A wave and this is the B wave. It is large wave. However, you see here the A wave is large, but the B wave is small. So if we divide B over A, then in the negative ERG, it will be less than 1. So this happens in congenital stationary night blindness, X-linked juvenile retinoschisis, and central or ischemic central retinal vein occlusion. This is important and asked in the MCQs. Regarding the interpretation of the ERG, so there will be like scotopic ERG and photopic ERG, and this will be of extreme value for diagnosis of fundus hereditary retinal dystrophies, like for example, retinitis pigmentosa. So as we know, in the retinitis pigmentosa, there will be bone spicules and pigmentation. There will be damage or affection to the scotopic vision first, or the night vision first, followed by the light day vision later on. So this will be the normal eye electrophysiology. Scotopic, this is the scotopic response by excitation by blue light, then by red light to stimulate. So the blue light will stimulate only the rods. The scotopic red will also stimulate the cones. Scotopic white, then 30 Hertz flickering response to isolate the cones, and photopic white for the cones. So the above or the above electrophysiological studies will mainly isolate the rods. The below, like the 30 Hertz flicker, scotopic white will be mainly for the cones. In retinitis pigmentosa, there will be, in the early stages, there will be affection of the rods more than the cones. But later on in the disease, in the advanced disease, there will be affection of both rods and the cones. Here is a patient with central retinal artery occlusion. You can see that there is almost non-recordable response. So the rods here, the rods and cones, they will show very, very minimal response comparing to the normal eyes. In the cone dystrophy, so the pathology here is limited to the cones. So you can see that there is some response in the rods. You can see the scotopic response is showing some response. Compare this. So this is scotopic, this is scotopic, this is scotopic. Compare this to the photopic, or the when we are only isolating the cones. You can see that the last two looks like flat. This is because the pathology is mainly in the cones, while the rod, there is some rod response indicating the presence of a cone dystrophy. Conversely, when we check a patient with congenital stationary night blindness, so the pathology will be mainly in the rods, you can see that the scotopic response is like flat line. But when we stimulate the cones by the scotopic white or the 30 hertz flicker response or the photopic white, there is some response, giving some response, meaning that the pathology is not in the rods or not in the cones, but it is mainly in the rods. So I hope that these examples will tell you or will illustrate to you how the electrophysiology will be helpful to differentiate between different hereditary fundus dystrophies. Finally, there is another electrophysiological study called the electrooculogram. So this test is used to measure the electrical potential, electrical activity between the cornea and the retinal pigment epithelium. And it will give it a response or give it a ratio called the Arden's ratio. So we are measuring the difference between electrical potential between the cornea and the retinal pigment epithelium in the light and then in the dark. So we got the highest response from the light, and we got the lowest response in the dark, and then multiply by 100%. And this what will result in a ratio called Arden's ratio. So the Arden's ratio will be the light peak divided by the dark trough multiplied by 100. If it is more than 180, this is normal. If it is between 165 to 180, this is a borderline. If it is less than 165, then this is a subnormal. And a difference between more than 10% in both eyes is significant. The most important application for the electrooculogram is the Best disease. Best disease is one of the common macular dystrophies, and the advantage or the privilege of electrooculogram is that it is not only be able to diagnose the cases or diagnose a case of Best disease where the patient can be present with normal visual acuity, but it will also detect the carrier state, even if the patient doesn't have any fundus pathology, even if there is no macular pathology, it will still be able to detect the presence of a carrier patient. Like if a patient, this is a normal EOG, will show Arden ratio of 2.18 in the right eye and 2.3 in the left eye. And in the Best disease, it will show Arden ratio of 1.1 and for the left eye, 1.1 as well. So this indicates the presence of Best disease in this patient. Okay. Okay, so I hope that this introduction about retinal investigations will be helpful to understand what is coming later and will also be helpful to the exam.